Good afternoon, and welcome to Empowering Nurses to Protect Patients, to protect themselves and their patients, exploring best practices in injection safety. The audio for today's conference will be coming through your computer speakers. Please ensure your speakers are turned on and the volume up. The next 4 slides will cover the continuing education information for today's webinar. The Centers for Disease Control and Prevention is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. The Centers for Disease Control and Prevention designates this live activity for a maximum of 1 AMA PRA Category 1 credit. Physicians should claim only the credit commensurate with the extent of their participation in the activity. CNE. The Centers for Disease Control and Prevention is accredited as a provider of continuing nursing education by the American Nurses Credentialing Centers Commission on Accreditation. This activity provides 1 contact hour. CEU. The Centers for Disease Control and Prevention is authorized by IACET to offer 0.1 CEUs for this program. CECH. Sponsored by the Centers for Disease Control and Prevention, a designated provider of continuing education contact hours in health education by the National Commission for Health Education Credentialing, Incorporated. This program is designated for a certified health education specialist and or a master certified health education specialist to receive up to 1 Category 1 continuing education contact hours. Maximum advanced level continuing education contact hours are available, and the CDC provider number is 98614. CPE. The Centers for Disease Control and Prevention is accredited by the Accreditation Council for Pharmacy Education as a provider of continuing pharmacy education. This program is a designated event for pharmacists to receive 0.1 CEUs in pharmacy education. The universal activity number is 0387-000-18-121-L05-P. This activity has been designated as knowledge-based. Once credit is claimed, an unofficial statement of credit is immediately available on TCEO online. Official credit will be uploaded within 60 days on the NABP CPE monitor. For certified public health professionals, the Centers for Disease Control and Prevention is a pre-approved provider of certified and public health recertification credits and is authorized to offer 1 CPH recertification credits for this program. CDC is an approved provider of CPH recertification credits by the National Board of Public Health Examiners. Effective October 1st, 2013, the National Board of Public Health Examiners accepts continuing education units for CPH recertification credits from CDC. Please select CEU as your choice for continuing education when registering for a course on TCE online. Learners seeking CPH should use the guidelines provided by the NBPHE for calculating recertification credits. Please visit their website for assistance. And just as a reminder, please mute your phone lines. In compliance with continuing education requirements, all presenters must disclose any financial or other associations with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters, as well as any use of unlabeled products or products under investigational use. CDC, our planners, our presenters, and their spouses or partners wish to disclose they have no financial interests or other relationships with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters. Planners have reviewed content to ensure there is no bias. Content will not include any discussion of the unlabeled use of a product or a product under investigational use. CDC did not accept commercial support for this continuing education activity. Injected medications are used in a variety of treatment settings to prevent, diagnose, and treat illnesses. Unsafe injection practices place the patient and medical staff at risk for preventable infectious and non-infectious adverse health events. The fifth webinar in the NICE Network webinar series, Empowering Nurses to Protect Themselves and Their Patients, Best Practices, Exploring Practices in Injection Safety, will address some of the more common issues related to safe injection practices. The objectives of the Infection Control and Prevention webinar series include describing infection control techniques that reduce the risk and spread of healthcare-associated infections, or HAIs, identifying unsafe practices that place patients at risk for HAIs, describing best practices for infection control and prevention in daily practice in healthcare settings, and applying standards, guidelines, best practices, and established processes related to safe and effective medication use. In this specific webinar, we will describe the essential balance between meeting immediate or emergent patient safety needs and performing all recommended infection control practices during clinical care. We will identify safe injection practices that are intended to prevent catheter-related bloodstream infections, and we will describe a type of injection practice that might occur in a hemodialysis facility that would potentiate a patient's risk for infection. So hello again, and welcome to today's webinar, Empowering Nurses to Protect Themselves and Their Patients, Exploring Best Practices in Injection Safety. My name is Erica Tyndall, and I am a public health analyst and infection preventionist at CDC's Division of Healthcare Quality Promotion. The mission of CDC's Division of Healthcare Quality Promotion is to protect patients, protect healthcare personnel, and promote safety, quality, and value in both national and international health delivery systems. As mentioned, this webinar is part of a series of infection control-related webinars that CDC will be hosting with the American Nurses Association and members of the Nursing Infection Control Education Network. Before we get started, there are a few housekeeping items to cover. We welcome your questions. Please submit any questions or comments you have via your chat window located on the lower left-hand side of the webinar screen anytime during the presentation. Questions will be addressed after all presentations as time allows. To ask for help, please press the Raise Hand button located on the top left-hand side of the screen if you need to chat with the meeting chairperson for assistance during the webinar. Also, the speaker slides from today's presentation will be provided to participants in a follow-up email. As a reminder, today's webinar is being recorded. Please visit our Tune In to Safe Healthcare website in a few weeks for the recording. Before I pass it on to ANA, I would like to take a moment to introduce our speakers. Dr. Chuck Griffiths is from the American Association of Nurse Anesthetists. Dr. Griffiths is a certified registered nurse anesthetist working at the Greater Los Angeles Veterans Administration Medical Center. He has a PhD from the UCLA School of Nursing. Dr. Griffiths is on the AANA Practice Committee Infection Control Task Force and lectures widely on infection control practices in anesthesia. Michelle Barrett is from the Infusion Nurses Society. Michelle has been a nurse educator with the Infusion Nurses Society since 2009. Her experience in infusion therapy has crossed all practice settings, from home infusion pharmacy to medical oncology infusion. Michelle has served as a member of the Institute of Safe Medication Practices Safety Consensus Committee. She has held a certification in infusion nursing for over 25 years. Dr. Carol Headley is from the American Nephrology Nurses Association. Dr. Headley has over 2 decades of nephrology experience. She obtained her undergraduate degree from Samford University in Birmingham, Alabama, her master's at the University of Alabama in Birmingham, and her doctorate from the University of Tennessee Health Science Center. While advancing her education, she remained professionally active in nephrology. She has served on numerous committees and boards that have helped to shape the framework of nephrology policy and practice. Dr. Headley served as a member of the Nephrology Nursing Journal Board for several years. She is also the primary author on several publications and edited a book on professional development, as well as several book chapters. Presently, she is employed as a nephrology nurse practitioner at the Veterans Affairs Medical Center in Memphis. Now I will pass it on to Dr. Shawn Ross from ANA.
Thank you, Erica. My name is Dr. Shawn Ross, and I am the Director of Nursing Practice and Work Environment at the ANA. For 16 years, nurses have been voted as the most trusted profession. Nurses spend the most time with patients and their families and are uniquely positioned to prevent the spread of infections throughout the healthcare experience. Injection safety and sharps needle stick prevention represents just one area where nurses have the power to stop the spread of infection. So why is injection safety so important? Adherence to evidence-based protocols and injection safety is important because you are breaking the barrier and creating a portal of entry in patients that are often immunocompromised. The CDC reported that from 2001 through 2011, there were at least 50 outbreaks of viral hepatitis or bacterial infections associated with unsafe injection practices in outpatient settings such as physician offices or ambulatory surgical centers. Unsafe medical injections cause irreparable damage, exposing the patient to bloodborne illnesses and life-threatening bacterial infections. Examples of these breakdowns in proper infection control include providers reusing needles, syringes, or single-dose medication vials, all of which are meant for one patient and one procedure. The ANA Sharp Injury Prevention Stakeholders Group was re-energized in 2017 and committed to preventing sharp injuries in the workplace. At the July 2017 face-to-face meeting of stakeholders and manufacturers, the group confirmed a common purpose: to protect patients and healthcare workers. To achieve this goal, the group identified the following 2018 focus areas: 1, policy and accreditation; 2, media and press; 3, safe OR pilot; and 4, terminology. Today's webinar is the 5th of 7 webinars within the NICE Network series, Empowering Nurses to Protect Themselves and Their Patients. Today's webinar will, 1, describe the balance between meeting immediate or emergent patient safety needs and performing all recommended infection control practices during clinical care. 2, identify safe injection practices intended to prevent catheter-related bloodstream infections. And 3, describe injection practices in a hemodialysis facility that would potentiate a patient's risk for infection. At this time, I will turn it over to Dr. Charles Griffith with the American Association of Nurse Anesthetists.
So, good morning, everyone. I'm Dr. Chuck Griffiths. I'm representing the American Association of Nurse Anesthetists, and it's our pleasure to join this discussion of safe injection practices. Sumitra, I don't have the control to advance the slides. We have no financial relationships with any commercial interests related to the content of this activity, and we will not discuss any off-label use during our presentation. Next slide, please. Our objective today is to discuss the components of safe injection practices to include safe parenteral medication preparation and administration. Next slide, please. So how did we get here? This is the AANA's journey on this slide, depicting our commitment to safe injections. The AANA has always emphasized the importance of safe injection practices, and we've always engaged in developing practice resources, such as our infection control guidelines. However, safe injection practices were really brought to the forefront in 2007 when a cluster of new hepatitis C infections were reported from patients who received care at a Southern Nevada outpatient endoscopy center. These infections were attributed to anesthesia professionals reusing single-dose vials of propofol, reusing needles, and reusing syringes. In total, 6 patients were affected with hepatitis C virus, but over 40,000 patients were informed of potential exposure. We knew that we were at the forefront of a crisis in our practice. The incident highlighted the need for increased awareness and vigilance related to safe injection practices, especially in our case for anesthesia professionals. In 2009, the AANA established a task force to increase and improve our evidence-based guidelines and resources related to infection control, especially with regard to safe injections. We established the Safe Injection Guidelines that detail safe injections in depth. These are actually separate from our infection control guidelines, which also discuss safe injection techniques. We are constantly updating these resources as new information and research becomes available. Today, we continue to stay abreast of best injection practices and work with organizations such as the wonderful CDC Safe Injection Practices Coalition, certainly the One and Only campaign, and the Nursing Infection Control Network, the NICE, to promote the message of one patient, one needle, one syringe, one time. Next slide, please. So why do nurses have to practice infection safety? Well, it's our duty as healthcare professionals and nurses to protect our patients and to keep them safe from harm. Infection control is patient safety because we are protecting our patients from getting an infectious disease while they are in our care or downstream even as a result of being exposed. You as a healthcare professional and me as a healthcare professional, we don't want to be responsible for harming patients by not practicing critical infection control measures. This would put our license and our job at jeopardy, but most importantly, the health of our patients in jeopardy. The outbreak that we discussed in the last slide in Las Vegas led to an outbreak of hepatitis C virus, which resulted in an investigation, patient lawsuit, jail time, and loss of licensure for some of the anesthesia providers who caused that outbreak. Next slide, please. So the One and Only campaign is a public health initiative led by the Centers for Disease Control and Prevention aimed at raising awareness among patients and healthcare providers about safe injection practices. The campaign aims to eliminate infections resulting from unsafe injection practices. As advanced practice registered nurses, we at the American Association of Nurse Anesthetists add our voices, our efforts, and our full support to this important CDC initiative to protect our patients. Next slide, please. So let's talk about safe injection and aseptic technique. It is important that we adhere to aseptic technique when preparing and administering injections. Hand hygiene is where we start and finish always and is critically important to preventing the spread of infection. Personal protective equipment such as sterile gloves and gowns, drapes, and masks can keep us and patients safe. Cleanse the patient's skin with proper agents to disinfect it prior to any injection therapy. It's important to consult the manufacturer's recommendations and guidelines for the appropriate use of these agents, such as alcohol, chlorhexidine, or povidone iodine. Also, other environmental considerations, minimizing traffic in and out of procedure rooms reduces the introduction of pathogens and keeps clean areas free of unnecessary objects. Be mindful of resources that you may share between patients, especially supplies that carry high risk of cross-contamination. These include objects such as tape rolls, scissors, hemostats, stethoscopes. These objects can easily become fomites, capable of spreading pathogens, and should be either discarded or disinfected after each patient use, according to manufacturer's recommendations. Always take precautions to prevent contact with non-sterile surfaces and dedicate necessary supplies to the sterile environment to prevent cross-contamination. Next slide, please. So safe injection preparation. The CDC has established detailed protocols for safe injection practices transformed into inspired educational graphics by the One and Only campaign. Let's take a look at the slide more closely. So for safe injection preparation, it's recommended that the pharmacy prepare and provide pre-prepared purchased syringes whenever possible for our use in the clinical area. When necessary, if we have to draw up our medications, we should draw them up in designated areas, not adjacent to potentially contaminated areas, such as, again, patient treatment areas. Any items that could have come in contact with blood or bodily fluids should not be in the patient preparation area. Access parenteral medications in an aseptic manner always. Do not redraw medications with the same needle or syringe. Always, always use a new sterile syringe and new sterile needle to draw up medications while preventing contact between the injection material and the non-sterile environment. Prepare drugs as close to the time of use as possible, and it's important to fit this into your clinical scenario. Label syringes with appropriate information such as their content, the preparer information, and beyond use date. Next slide, please. So for safe injection administration, let's go over, again, some of the important basic components of safe injection practices. So use one needle, one syringe, entered one time. Never reuse a needle or needleless access device, even on the same patient. Always assure that ports are clean with alcohol prior to entry. Scrub the hub and scrub flip-top vials once the top is removed, and ampule neck before entry. Do not use IV solutions as a diluent or as a supply for more than one patient. These are single patient items. Use individually wrapped saline syringes for line flushes and diluents. And of course, it's always important for us to know all the differences between single-dose vials and multi-dose vials. Next slide, please. So let's talk about those differences. As an essential component of safe injection practices, it is important to understand the difference between single-dose and multi-dose vials. Single-dose vials have no preservatives and must be entered only one time for one patient. Any leftover medication must be safely disposed of and not used. Multi-dose vials can be used for more than one patient or procedure, but only if stored away from clinical care areas. Best practices is still considered to treat multi-dose vials always as single-dose vials and discard them at the end of patient treatment. This is to prevent inadvertent contamination of the vial through direct or indirect contact with potentially contaminated surfaces or equipment that could then lead to infections in subsequent patients. If a multi-dose vial enters an immediate patient treatment area, it should be dedicated for single patient use only and then discarded. Use only sterile, unused needles or syringes to enter even a multi-dose vial. It is important to mark the beyond use date and or time on the vial so it can be discarded beyond that date and time. Next slide, please. So for improving practice, what can we do? We need to always at all times stay aware of the science and practice of infection control prevention and management as it continues to evolve rapidly. All of us healthcare professionals need to foster a culture that integrates the routine use of best infection control and prevention practices amongst our colleagues and our students. Contribute to quality improvement, education, and research activities to keep our patients safe and infection-free, and always maintain familiarity with infection prevention and control practices, best practices, as they are updated constantly in the federal, state, and local statutes that we all function under, and regulations, as well as nationally recognized infection prevention and control practices and guidelines from our CDC. Next slide, please. You can certainly learn more about our AANA resources. We have numerous documents available now online, including we have an entire document about infection prevention and control guidelines that's comprehensive and specifically targeted at anesthesia care. We have documents on safe injection guidelines for needle and syringe use. We certainly have a full availability of one and only campaign documents and materials, and we have injection safety resources available as well. You can find all of these important documents and more at www.aana.com/infection-control. You also, all of us, should constantly be visiting www.cdc.gov/injection safety for additional CDC resources. Thank you all for your attention. Next slide, please. And now I'll turn this over to my colleague, Ms. Michelle Barrett.
Thank you, Chuck, and welcome to everyone attending the webinar today. I'm very glad to be here and happy to share some information with you on how we as nurses can protect our patients and reduce central line associated bloodstream infections by practicing safe injection. As previously stated, I have no conflicts to disclose. Our learning outcome for this will be attendees, you'll be able to identify 3 safe injection practices that are intended to prevent central line associated bloodstream infections. So catheter-related or central line associated bloodstream infections are caused by the introduction of microorganisms or bacteria fungi, viruses into the bloodstream. Since our bloodstream is a sterile environment, our immune system will do everything in its power to attempt to destroy those invaders. If the immune system can't remove those, the microorganisms quickly overrun the bloodstream, take over, and cause a bloodstream infection. Patients that experience bloodstream infections may have absolutely no signs or symptoms, or they may have symptoms ranging from very high fevers to delirium. Bloodstream infections are confirmed by laboratory. They, if they're catheter-related, need to be the microorganisms need to be associated only with the catheter and not secondary to another infection that might be present. So central lines go by several different names. We know them as central lines, we know them as CVCs, central vascular access devices, CVADs, or just plain lines or catheters. They're thin hollow tubes that are inserted through the skin into a major vein of the body, and most commonly in the area of the chest. The end of the catheter is advanced to the point close to the right atrium of the heart. That's where it gets its central line position. And the position of that catheter tip needs to be confirmed by chest x-ray. Catheters are used to administer IV products such as medications, solutions, parenteral nutrition, blood or blood products, or even to obtain laboratory specimens and tests. Some of our catheters are designed specifically for hemodynamic monitoring. The Joint Commission has estimated that nearly 3 million CVCs have been placed annually in the United States. While our catheters have become a reliable means to obtain vascular access, they're also a major risk for bloodstream infections. $80,000 CLABSIs, which are the central line associated bloodstream infections, are estimated to occur each year in the in ICUs alone. If we take that number and increase it to look at the entire hospital area assessed, that number can increase easily to an estimated 250,000 patients. What causes then these infections to take hold? We can get infections from several places when it comes to our catheters and our infusion systems. We can get infections from the site, which is why we do catheter sterile dressing changes to those sites. When catheters are inserted, they can drag contaminants, bacteria, into the bloodstream that sets up on the catheter itself and within the catheter, causing bacterial migration. We can have, as this photo shows, bacterial biofilm growth around the catheter and on the needleless connectors, the catheter hubs as well. These are most often caused by bacteria and fungi. This infection can happen anytime from the point that the catheter is inserted until the device is removed. Risk factors for our patients come in two varieties. They're either non-modifiable or modifiable. Our non-modifiable are the patient's gender, the patient's age, and what underlying conditions or diseases they may have. Modifiable, or things that we can take a look at and maybe intervene, are what type of device we're using, whether the device is tunneled or non-tunneled, how many lumens it has, how long are we looking for the therapy to actually last? Will we be prolonging the patient's hospital stay? Was the device put in an emergency situation, or was it elective? That may determine how well the skin was prepared ahead of time. The insertion site, femoral sites and jugular sites, are more prone to infection. And the preparation of the site, hopefully maximum sterile barrier precautions were instituted. And the skill of the inserter is also another risk factor. Those that have less experience may have more trouble with infections. Outcomes related to bloodstream infections are deadly, and they can be very expensive. Bloodstream infections can cause, one case can be upwards of $36,000 to treat. And Medicare, the Centers for Medicare and Medicaid Services, no longer pay for these never events, which eclampsia is considered, if it occurs during a hospital stay. Bloodstream infections are indeed deadly. Of 100,000 healthcare-acquired infections that occur each year, a third of them are eclampsia-related. They're considered one of the most deadly healthcare-associated infections, with mortality rates reaching as high as 25%. Thankfully, research is showing that eclampsias are not only preventable, but changes in our practice have created changes in these outcomes. So we change our practice by looking at various single entities that show these practices help prevent infections. We take these practices and gather these together into a group called a bundle. The Michigan Keystone Project, the CUSP Comprehensive Unit-Based Safety Program, or CUSP, demonstrated that with a change in insertion practice, there was a significant result in eclampsia reduction, and it was sustainable. So we need to start at the beginning with the insertion, take all these things that we know help prevent infection, and put them together. Over a 5-year period, a 46% reduction in the rate of eclampsias was reported by the Hospital Engagement Network, resulting in a savings of over $15 million. Follow-up studies have found that these eclampsia reductions are maintained for months. So once we get the insertion done and we know that these things are decreasing our infections, we need to be able to maintain that. So we need to go beyond the insertion bundle and find out what keeps our patients safe with our injection practices. The risk still remains for eclampsias, despite the fact that we've done what we can at the insertion. The whole time the catheter is in, it places our patients at risk for bloodstream infections. One study showed that 71.7% of eclampsias occurred in more than 5 days after insertion, indicating the need to pay more attention to our catheter maintenance. Our challenges remain. Beyond the insertion bundle, evidence is lacking to support any kind of a good practice, so we need to turn to and rely on our best evidence that's available. And how do we ensure success? We identify key components such as education, evaluating our practices, and keeping up on best practices. So what are these best practices that are going to prevent and help reduce eclampsia in our patients? The CDC has shown that some healthcare providers don't practice hand hygiene around half the amount of times they can. The Joint Commission states that the hand hygiene is the most important infection prevention strategy for hospital-acquired infections, which do include bloodstream infections. So hand hygiene is one of the most important things we can do. The next thing is our entry points into our IV systems. Our dressings cover our insertion sites. We know that those are well protected. The other way we introduce bacteria into the line is through needleless injection ports. We need to make sure that those are thoroughly scrubbed with alcohol and infected or prior to injection, totally disinfected. Catheter hubs need to be scrubbed with alcohol. Connectors scrubbed thoroughly with alcohol. And if anything, make sure that that alcohol has the time it needs to dry. If you don't disinfect a port, do not inject into that port each and every time. Safe injection practices also mean don't reuse a syringe that you've used to flush a needleless connector prior to or after giving a medication more than one time. Give your medication, flush your line, give your medication, you use a separate syringe. One time, one patient, one only. This applies to your tubing changes and your dressing changes as well. So our outcomes, we're looking to reduce significantly our CLABSI infections. 0 is indeed possible, and you are the key master to making that happen. Your keys to reaching 0 and keeping it at 0 are hand hygiene, disinfection of all your injection ports prior to any use, and that is every single time you use that injection site. And never, ever, ever reuse any of your syringes more than the one time for the one patient. So thank you for allowing me to present this afternoon. I appreciate your time and your interest. Please visit the Infusion Nurses Society if you'd like more information at www.ins1.org. And my references. And I'd like to turn the presentation now over to Carol Headley.
Thanks, Michelle. This is Carol Headley, and it is a pleasure to be able to present on behalf of the American Nephrology Nurses Association and in conjunction with the Centers for Disease Control and for Prevention and the American Nurses Association. The title of my presentation today is Healing Hands, and I want to start out with just a little explanation for the title because there's a question mark after it. Healthcare workers' hands, for the most part, promote healing, but occasionally and unintentionally can also potentially transmit pathogens and do harm. So today's presentation is going to talk about practices related to the outpatient hemodialysis population. Why are we going to talk about this population group? Well, it's because the number one cause for their hospitalization is infection. And infection is the second leading cause of death right after cardiovascular disease for this special population group. And injections, they have a lot of injections that occur in the dialysis unit. Saline, heparin flushes, erythropoiesis-stimulating agents, vitamin D, parenteral iron. A lot of injections go on within this outpatient hemodialysis facility. And the preparation practices for these medications are diverse. They're not always consistent. So my goal is that we make a more conscientious effort to make sure that we adhere with the guidelines for medication preparation and make it habitual, make it continuous, that we do the same thing every time and adhere with the guidelines. So the objective for today is I want you to be able to describe a type of injection practice that might occur in a hemodialysis facility that would potentiate a patient's risk for infection. Let's start out with some definitions. A microbiome is your individual makeup of microbes both inside and outside the body. A lot of us don't really think about it on a daily basis, but we are made up of trillions of bacteria and viruses and bacteriophages and protozoa and fungi. They live inside and outside our body. And I want to talk particularly about our hands. Our hands have resident flora, but we also have transient flora. And it's this transient flora I want to talk about. It's what we pick up from the environment and can potentially transmit to our patients. When we talk about injections in a dialysis unit, we also have to think about the terms flush, push, infuse, or lock. And the fomites within our dialysis unit. The fomites are those inanimate objects or structures capable of transmitting an organism. The organism can survive outside the body. It survives on the surface of our hands, and it survives on objects such as doorknobs, TV controllers, dialysis machine, the bedside table, the chair table, even the curtains that surround our patient can harbor potentially infectious pathogens. And I also want to talk about aseptic technique. Aseptic technique, as defined by the Centers for Disease Control, is the manner of preparation and handling material with the goal of preventing microbial contamination. So some of the medications that we routinely administer within a dialysis unit are erythropoiesis-stimulating agents, vitamin D analogs, parenteral iron, heparin, antibiotics, and flushes, both saline and heparin flushes. Well, all of these do not come immediately ready to be injected. They require preparation. And that preparation needs to be done in a specific manner, and it needs to be done away from the immediate patient care area in a designated medication preparation area. Now, I'm not going to read off all of these microbes, but I want you to realize that these microbes are both gram-negative, gram-positive, and fungi. And these microbes can survive for long periods of time in that fomite, in that object that's in the immediate patient care area. These microbes can survive for days, weeks, even months. And the environment of a dialysis facility is especially prone to harbor blood-borne pathogens such as hepatitis B. And as we know, hepatitis B can survive on an inanimate object for up to 7 days. And it can also, the dialysis unit is also prone to blood-borne pathogens such as hepatitis C, HIV, and other special organisms such as methicillin-resistant Staph aureus, Clostridium difficile, and vancomycin-resistant Enterococcus. So these potentially infectious pathogens can live on the environmental surfaces, and we can transfer these pathogens to our patients. We can transfer them between other patients or from the environment to our patients. So how are we doing? Well, since from 2008 to 2016, we've had numerous breakouts of hepatitis B virus and hepatitis C virus, as documented by the Centers for Disease Control and Prevention. And these were traced back to errors or lapses in hand hygiene and medication preparation and practices. So why are our patients so susceptible to infections? It's because they're chronically immunosuppressed and because they have frequent contact with the healthcare system and the exposure of the extracorporeal circuit. They have blood exposures as well that makes them particularly susceptible to infections. So when we talk about medication preparation within a dialysis unit, we want to make sure that this takes place away from the immediate patient care area. Consider the patient care area contaminated. So you want a designated place where you prepare your medications, and it requires a special knowledge base. Keep that area clean. Don't allow people to drop off blood specimens in that area. Don't let staff eat or drink in that area. Keep it completely separated to avoid contamination. And while you are preparing a medication and a machine alarm goes off, then take off those gloves, perform hand hygiene, take care of the patient alarm, perform hand hygiene again, put clean gloves back on, and then return to the preparation area. So you got to think about hand hygiene at every single point of care. So aseptic technique is the definition I provided earlier is from the Centers for Disease Control and Prevention, and we want to make sure whenever we don gloves that we recognize that the gloves do not alleviate the need for hand hygiene. We need to perform hand hygiene before we don the gloves because gloves can have tiny holes in them. And when we make connections for injecting medications, make sure you scrub that hub. It's the friction that decontaminates. So we want to make sure we make sterile to sterile contact. Don't let the tip of your glove touch either of the sterile surfaces when you're making injections. And IV solution bags. These are one time, one patient. Even if you only use 100 cc's, discard that bag after use. Never use an IV solution bag for a common source for multiple doses for multiple patients, such as adding heparin to the bag and creating a multi-dose heparin flush where everybody withdraws. The IV solution bag is intended for one patient, one time, and discard. Never save an IV solution bag to use on another patient, even if you only used a small portion of that bag. And I want to talk a little bit about saline flushes that are prepackaged saline flushes. Sometimes you might be tempted to squirt out some of this medication and draw up squirt out some of the saline flush and draw up a medication. This is not the intent for manufacturer intent for saline flushes that are prepackaged. Only use what the manufacturer's intent was, and these are purely made for flushing. And make sure that when you take it out of the package that you immediately use it. You cannot guarantee the sterility of the saline within the flush or the heparin within the flush after you remove it from the package. Never put a medication on top of a machine and use it later. Never administer a portion of the saline flush and then save a portion to use later. One time, one patient, and then discard after use. The saline flushes are not universally processed in the same way. Some are processed with terminal sterilization, whereas others are not. So once removed from the package, then you cannot guarantee the sterility, so you want to make sure you use that saline flush immediately. So let's look at single-dose vials versus multi-dose vials of erythropoietin stimulating agents. So look at the volume of these vials. You cannot tell whether or not it's multi-dose versus single-dose by looking at the volume of the vial. The Centers for Disease Control and Prevention has recommended that we go to using single-dose vials. So what kind of vials are you using in your dialysis unit? Go back and look and see. If you are using multi-dose vials, try to make them a single-use vial. If you're using a single-dose vial and you don't use all the medication within that single-dose vial, discard. Do not try to draw multiple doses from that single-dose vial. And never put in a needle and withdraw multiple doses from a multi-dose vial from that same needle that's sitting in that vial. So the critical step to avoid microbial transmission or pathogen transmission is what? Hand hygiene. We've been harboring on it, but it's so incredibly important that we perform hand hygiene at several points during the day. Before patient contact, before performing a procedure, after contact with body fluid or contact risk, after patient contact, and after contact with patient surroundings. Remember, we need to consider the environment around the patient contaminated, and we need to make sure we perform hand hygiene before and also after. So what are we talking about when we're performing hand hygiene? Most of us know that the alcohol hand rubs and soap and water are available. So when do we use which? Alcohol hand rubs are shown to be highly efficacious, but you would use soap and water if somebody had diarrhea or had nausea and vomiting. Research has shown that we cannot remove the spores with the alcohol hand rub, but we can remove the spores of Clostridium difficile with soap and water. The other thing is gastroenteritis and viruses. We need to use soap and water for those. And try to segregate patients who have diarrhea or nausea and vomiting. Put those patients in a temporal kind of segregation position away from other patients. Actually, there was a study done by the British Medical Journal in 2002 that showed that alcohol hand rubs are highly efficacious and can reduce the microbial load on hands just as effectively and sometimes more effectively than antimicrobial soaps can. So how do we know how we're doing? Because we're not always conscientious about what we're doing. So we need to do audits. That's the critical measure for determining how your facility, how your hemodialysis facility is performing. Just like a secret shopper, we need to have secret auditors that are incognito, and they are doing surveys of to how you're performing in injection safety and also in hand hygiene. At the bottom of this slide, there is a URL that you can go to that provides great, wonderful tools to use for auditing for multiple care practices that are done in dialysis units. I would encourage you to download these. They're free and they're easy to use. And it doesn't take that long to do a hand hygiene audit within the dialysis unit or injection safety audit. There are several auditing forms that are available free of charge from the Centers for Disease Control and Prevention to perform auditing measures and critical analysis and monitoring within the dialysis unit. Truthfully, there's no other way to know how you're doing until you actually do some audits. So let's choose safe practices. Choose hand hygiene before, during, and after. Your hands need to be instruments of healing, not of harm, not transmitting potentially infectious pathogens. Saving time or money by making supplies stretch is not always wise. So if you have that single-dose vial and you're tempted because you didn't use all the medication within the vial to use it as a multi-dose vial, don't do it. Don't do it. That's not what the manufacturer intent was. The manufacturer intent is single dose for that one patient. Once you open it, once you penetrate the top of that, you cannot guarantee the sterility of it. Even when supplies are low, make contingency plans that enhance your safety of your patients. Pre-filled saline flushes are intended to be used for the purpose of flushing, not for admixing, not for adding a medication. Remember what supplies are once and done. Syringes, needles, IV solution bags, once and done. And now I'm going to turn it over to my colleague, Dr. Sean Ross.
Thanks so much, Dr. Headley. This is Sharon Morgan, Senior Policy Advisor at ANA. Dr. Sean Ross had to leave, unfortunately. We've heard a lot of great information today in the webinar exploring best practices in injection safety. Some key points to remember. If you haven't gotten it by now, one means one use, one patient, one time. Hand hygiene is not optional. Appropriate hand hygiene will reduce the likelihood of microbial transfer and development of HIIs when preparing and administering medications. And finally, as the science and practice of infection prevention and control continues to evolve, participation in quality improvement, education, research activities helps keep our patients and ourselves safe and infection-free. I'll now turn it over to Erica Tyndall, CDC.
Thank you to all the speakers for your time and expertise today. As a reminder, for participants, please submit your questions via the chat window located on the lower left-hand side of the webinar screen. And it actually looks like we received a few questions already. I will read one of the questions. One was related to the home care environment. The question is, can one insulin syringe be used to draw both NPH insulin and regular insulin as to avoid giving the patient two injections? If so, what is the recommendation on using one syringe for two different vials for one patient? The CDC does not have a recommendation for this practice, and we don't have a recommendation that addresses this practice in the home. We would actually consider this practice compounding in the healthcare setting and recommend that healthcare workers follow the USP General Chapter 797 standards. There were a few other questions related to CRNA practices. Dr. Griffiths actually has answered a few of those in our chat box, but there's one in particular that we would also like to address. The question is, what is the recommendation for how far ahead can the CRNA prepare IV push medications prior to surgery? And the CDC recommends drawing up the medication as close to the time of administration as possible to reduce the risk of microbial contamination and also to ensure the stability of the drug. So we're getting close to the end of the webinar. I think that's all the time we have for question and answers. So thank you for submitting your questions to the chat box. And before we end today's webinar, we want to give you a little bit of information about continuing education credit. You must complete the continuing education post-test and evaluation. Please be sure to follow the detailed instructions that you will receive by email. You must complete and pass the post-test activity at 66% to receive continuing education credit. And for those of you on the phone who currently aren't logged into Ready Talk Online, to obtain continuing education, please visit the CDC website at www.cdc.gov/TCE online in the next few days to obtain CE credit. Again, a follow-up email will also be sent after the webinar with detailed instructions about completing the continuing education post-test and evaluation. And with that, I'd like to thank our speakers as well as all of you for taking the time to join us today and for your commitment to keeping your patients safe. Thank you so much.